Good afternoon, my respected judges and the dignitaries present here. My topic is the braving the hypothesis. Does the spontaneous retinal venous pulsation exclude the raised intracranial tension? As we know, spontaneous retinal venous pulsation is a subtle rhythmic narrowing and dilatation of retinal vein, and which is synchronous with cardiac cycle. It is evident in up to 90% of normal population. SVP is a result of fluctuation of the pressure gradient between the intraocular and the retrolaminar cerebrospinal fluid pressure. Several neurological disorders can elevate the central CSF pressure and obscure the SVP. So why does the pulsation really matter? Because it is well known that from clinical knowledge that elevated ICP preclude SVP. The study is going to elaborate how the SVP and raised ICP can represent two separate clinical scenarios. As we know, the retinal vein, though not a complete part of optic nerve and brainstem, therefore the direct correlation with CSF pressure variation is beyond theoretical acceptance. The aim of my study is to investigate the clinical dictum that presence of cerebrospinal spontaneous retinal venous pulsation refute the possibility of raised intracranial tension. It was a prospective interventional study done in a tertiary care eye center of Eastern India in between June 2017 to July 2018. I included those cases who admitted with any neurological illness and idiopathic intracranial hypertension. I excluded those cases who presented the altered sensorium, poor GCS value, optic neuritis, hazy ocular media, glaucomatous optic neuropathy, and pseudopapilloedema. After including 43 cases and written consent was taken when the sensorium is good, chronic systemic drug and concurrent medical and surgical history on substance abuse was taken. General examination done for an assessment of the cognitive function and orientation of the patient. Physical examination done to rule out the important things like anemia, elevated blood pressure, cranial nerves, and gross sensory and motor evaluation. The ocular exam included anterior segment evaluation, baseline visual acuity, intraocular pressure measurement, ocular motility, deviation examination, dilated stereoscopic examination by 90-degree lens, assessment of the central retinal vein thickness, and the venous pulsation was found to be positive if it was evident at the point of CRV and its entry into the optic cup. Lumbar puncture and pressure assessment. The patient underwent lumbar puncture as a routine procedure as the quantitative assessment of the ICT could not be done. So we depended on the opening pressure, and according to the neurologist opinion, we guided the theory of, we considered raised ICT if the pressure is found to be more than 30 millimeter of H2O, and if it is normal, it is considered to be less than 30 millimeter of H2O. So venous pulsation and wide assessment of central retinal vein. We followed the classification postulated by Hedges et al., which shows grade 1, which is up to 33% of vessel change, and 33 to 66% change in diameter, which is grade 2, and more than 36% obliteration of the vessel diameter is grade 3. The total cases was 43, the mean age of presentation 42.7, the mean duration of hospital stay 11.1 days, and median time interval between SVP estimation and LP was 53.4 minutes. We have found that clinical cases, the peripheral and the most number of cases patients presented with persistent headache, followed by possible CNS inflammation, most common MS, followed by peripheral nervous system symptoms like Gaberi syndrome and ATM. This chart is typically showing the presentation of my patients, where less than 30 millimeter of mercury, which is the normal ICT, SVP was absent in 7 cases but present in 24 cases. Similarly, more than 30, which is the opening pressure is comparatively high, systemic venous pulsation was present in 4 cases. And absent in 8 cases. The test values are, sensitivity of the test was found to be 0.77 and specificity 0.35. Similarly, positive predictive value are 0.75 and negative predictive value is 0.35. So researchers have found the consensus the SVP is usually abolished when ICT reaches beyond 20 millimeter of H2O. But in this study, we followed the upright posture for ophthalmic examination and doing LP later to avoid the sudden upset of ICT when the patient gets upright from supine posture. In our study, the proportion of patients with normal ICP was more than those with high ICP. In statistical terms, it would affect the positive predictive value, but not the sensitivity of the test. Idiopathic intracranial hypertension, is it found to be a loophole? Because it is a condition when elevated pressure was with no obvious cause. Prevalence is less than 1 million per case in India. These patients present with mild diminution of vision, headache, occasional weakness of lateral rectus muscle. As the CT and MRI found inconclusive regarding any organic brain lesion. We come across 3 such cases were diagnosed with IAH with raised ICP, but with not corroborative disc findings. The studies have done the spontaneous venous pulsation could not be a sole guide for the assessment of pressure physiology by Moret et al. Similarly, Dinkin M et al. In 2011 showed that serial digital photography of the CSF in order to track the CSF relationship with it. SVP, if absent, despite mild to absent disc edema, could point towards idiopathic intracranial hypertension. So to conclude, I can say that a PPV of 0.75, which is my finding, ostensibly identify the normal SVP is common in normal ICP, though it is far from absolute value 1. The negative predictive value of 0.35 points that all raised ICP did not resulted in absent SVP. The statistical outcome help us to identify the notion that though cross-sectional survey SVP could not be a sole guide for the ICP judgment. Conversely, raised ICP, which is undoubtedly clinical emergency, could not be evaluated on red flag sign by observing the SVP only. Serial digital photography of entering CRV is crucial for the local disc pathophysiology. This study has some limitations because it was done on some smaller population. Grading of the vein could not be done serial imaging. We solely depend on the neurologist opinion regarding the ICT. We did not consider radiological evaluation instead of primarily clinical finding help us to formulate the cases. We invite the future research on optic disc and retinal vein interrelation. Thank you.